this is X-ray KUB. A KUB X-ray is always taken from the level of 11th thoracic vertebra to the lesser trochanter, so as to cover the entire kidney, bladder and the ureter as well as the urethra. So this patient underwent an ultrasound abdomen, which is the first screening modality of choice, which showed a 11 millimeter stone in the ureter with hydroureteronephrosis. So this is a digital X-ray KUB. So here we can see the vertebra. So we can see a RO shadow in the right side at the level of L3, lower part of the L3 vertebra. So this is the ureteric calculus, which is of size of 11 millimeter. Usually when you have ureteric calculus of this size, we decide the location of the ureteric calculus in X-ray as well as ultrasound. In ultrasound, they usually determine whether it is above the level of iliac vessel crossing or below the level of iliac vessel crossing, and accordingly they give it as either upper ureteric calculus or lower ureteric calculus. Whereas in the X-ray, the landmarks are superior and inferior border of the sacroiliac joint. So in between the superior and the inferior part of the sacroiliac joints, we term it as a mid ureter, whereas above the level of superior border of the sacroiliac joint, it is known as the upper ureter, and below the level of inferior margin of the sacroiliac joint, it is the lower ureter. So a mid ureter and a lower ureteric calculus are technically easier for urologist, whereas an upper ureteric calculus, particularly that too above the level of L3 vertebra, usually is challenging, just because of the fact that there is more chance of migration because of the force of stone lithoclast as well as the irrigation flow. So luckily or unluckily, we have a case in the upper ureter. Let us see what to do. So what are the options in this case? Can it be treated medically? Usually a calculus of less than 7 millimeter is medically treatable, whereas a stone of more than 9 millimeter invariably needs a surgical treatment. So among the surgical treatment, the best modality of surgical treatment is a ureterorenoscopy lithotripsy. It can be done with a semi-rigid ureteroscope, which I am going to do it right now, or an option of a flexible ureteroscope can also be kept in mind. So in case of flexible ureteroscope, energy source to break the stone needed is a laser, which is usually not transportable. So we are going to use a pneumatic lithoclast along with a semi-rigid ureteroscope. Okay, let us move on to the case. Sir, irrigation. Camera. Okay. Lithoclast connect பண்ணிக்கங்க sister. Light cable. So what I am using right now is a ureteroscope. This is a 8.5 French ureteroscope, which means that the circumference of the ureteroscope at the tip is 7 millimeter and the circumference at the base is 8.5 millimeter. So it's a 8.5, and still I have a smaller one, which is a 7.5 ureteroscope. So the ureteroscope comes in different sizes, and accordingly we use it. Camera connect. So for me, I always go in for a 8.5 ureteroscope just because it's sturdy, and my routine workhorse is always a 8.5 ureteroscope. Monitor turn பண்ணி hidden raise பண்ணிக்கலாம் sir. So whenever it comes to upper urinary calculus, I always raise the head end since the chance of stone migration is always there. Light on. Light on. Light on, camera on. Okay, இன்னும் கொஞ்சம் கொடுத்துங்க சார். Okay. So you can see the camera right now. Pump பண்ணு சக்தி. Gauze piece. Next. Okay. Okay, the settings do vary with the different scopes. Hysteroscope in the math. Hysteroscope. White balance pen. Okay. Light increase பண்ணிக்கங்க. Okay, max. So this is the urethra. So we are seeing the penile urethra right now. So this is the most dilated part, which is the bulbar urethra, and here we see the contracted part, which is the membranous urethra. Okay, once you cross the membranous urethra, then you have the prostatic urethra. Here we see a projection in the 6 o'clock position, which is the verum montanum, and these are the right and the left lobes of the prostate, and this is the bladder neck. Now once you cross the bladder neck, we enter the urinary bladder. Okay, so this is the urinary bladder. Here we see the trigone, which is nothing but a triangular area between the right ureteric orifice, which is seen over here at the center. This is the left ureteric orifice. So that particular area over here is the trigone of the bladder. So this is the posterior wall of the bladder. You can see the vascularity over here, and
hello,
as you see laterally, you can see the lateral wall of the bladder.
The picture is not clear. Dr. Gopinath? Yes,
yeah.
Yes, maybe. Yes.
Okay, can you see?
No. Yes, now
can you
maybe
see, sir?
slightly focus a bit. Yes, now it's
okay.
better.
Guide wire. So this is the view over here. This is the urinary bladder. So you can see the anterior wall of the bladder, dome, posterior wall, so right ureteric orifice, the left ureteric orifice. So this patient is having a right ureteric calculus. Guide wire. So I am going to enter. Before entering, we usually pass a guide wire. So the guide wire is of hydrophilic nature. So it sticks to water and goes along the pathway of water. So now I am passing the guide wire into the right ureteric orifice, and over the guide wire I am entering with the ureteroscope. Pump. Sometimes ureteric orifice will be too paddless. To allow the scope easily. Pump. Okay. So now we have entered the ureter. So I am withdrawing the guide wire, going across. This is the lower ureter, and here we can see the pulsations behind. Okay, so this is the place where the ureter crosses the. Can you appreciate the pulsations?
Yes, sir.
Okay, this is the place where the ureter crosses the iliac vessels. Okay, so it is one of the site where the stone usually gets lodged. So it's a place where the iliac vessel compresses the ureter and causes a mechanical compression. Okay, so I am going above. So with the guide wire in situ, I am entering inside. So ureter is tortuous. So the guide wire helps you to straighten the ureter and go along. Okay. Can you see the stone over here?
Yes, sir.
Okay. So the stone, so this type of stone, which is, pull it can be, usually 75% of the stones are calcium stones. Pull rod kudunga sister. So these type of calcium stones mostly coupled with oxalate in the form of calcium oxalate. Okay. So these calcium oxalate stones can be of two types, calcium oxalate monohydrate stone or a calcium oxalate dihydrate stone. Rod sister. So this looks like more like a monohydrate stone, which is usually easily breakable. Foot switch. So you are visualizing the stone right now, which is impacted over here. You can see the edema over here. That's what which is preventing the foot switch. Foot pedal. Okay. So which prevents the stone from coming. Bucket. A urologist literally bathes in patient's urine or irrigation, whatever it may be. Okay. So that's the reason probably I always prefer doing operating at last if ever some list of cases is there. Just pump. So I always tend to have a traction over it. Okay. So you can see the rod over here which is touching the stone. So now we can see the pneumatic lithoclast which is breaking the stone. Multi. Okay, can you see? So the stone is being fragmented into small bits. So there are multiple basket sister, multiple energy sources to break the stone. This is a simple and a cheap one which is called as a pneumatic lithoclast, which uses compressed air, either a compressed air if it is available or oxygen from the hospital central source or from the Boyle's apparatus. Okay, down pump. So you can see the stone. So because of the irrigation it is moving up. I am just going to basket the stone. Close, close, close. Open. Open sister. Yes. Yes, I have basketed the stone right now. Leave it. Next. Rod. So this basket prevents the migration of stone above. Sorry. Head and low. Head and low. Left side. Table tilt towards the left side. So this is the kidney. So this stone, as I already told, has migrated to the pelvis. I am trying to retrieve it from the pelvis. So these are the calyx which you are seeing over here. Head low, sir, and left side tilt. So we have to maneuver the thing so as to get the tiltings. Okay. Basket sheath. So I am trying to retrieve the stone from the renal pelvis. This is the renal pelvis. The stone has gone inside the renal pelvis. So in this case, either you can retrieve it like this, or you can put a flexiureteroscope if you have it. Okay. Can you get a lithoclast? Rod. So I have basketed from the renal pelvis. Rod kudunga sister. Basket putching. Basket. Sister, hold the basket. Basket is the pudding. Just hold it. Okay, I had brought the stone which has slipped inside the kidney pelvis to the ureter. Now again I am trying to break. Okay. Don't pump. Putting rod. Yeah. So again and again it is slipping inside the pelvis. Sakti, lift one. So this is a retinol basket which is a whose tip is blunt so that it doesn't injure the kidney. Okay. Kidney lift பண்ணுங்கப்பா. Yes, lift above. மேலே போய் lift பண்ணு, don't toss. Lift மட்டும் பண்ணி புடி. Yes. Rod. So we had broken into small fragments. This is that large fragment which is still evading us. Hold it. Waiting sister. Waiting. Leave it. Pull பண்ணி புடி. Just pull above. Okay. Shit. Lift above. Lift பண்ண மேல. அதே மாதிரி லிஃப்ட் பண்ணி பிடி, அவ்வளோதான். லிஃப்ட் அபோ. எஸ். ராட். டைட்டாக இழுத்து பிடிங்க. பேஸ்கெட் இழுத்து பிடிங்க சிஸ்டர். Yes. So you must gently grasp the basket as well as make the stone to fragment. Okay. So this pneumatic lithoclast always gives a force which makes the stone to migrate. Okay, so there is a retropulsion. What do you call this? A movement of stone in the anticlinal direction towards the kidney.
Today only for 5 minutes.
Leave it. Okay. Multi. So we had basket the stone, brought and kept in the upper ureter. This pump. Okay, leave it. Okay, you are visualizing the stone fragments. So the tip of this lithoclast, which we are breaking the stone, is size of 0.8 millimeter. Leave it, sister. 0.8 millimeter. So we always compare the stone fragment size with this tip of the lithoclast probe. So again a fragment has slipped into the renal pelvis. Renal pelvis lift panna. Just lift it above. Okay, lift. Yes. Rod. So if it is in the lower ureter, it is a simple process. There is not much of manipulation, basketing the stone. No, not much of migration. Hardly takes around 15 minutes. The hand level. Whereas if it is in the upper ureter, these things do happen. Pump. So I am having a feel of the stone. Yeah, okay. This is the core of the stone, hence it takes some time for it to break. Pump. Leave it. Just a bit rinsed. Idappadi. Okay, leave it. Just do it. So these are the stone fragments which are broken. Idappadi. Okay. Last few fragments. Can you get me rod? Rod, the handle. Basket. Rod. So these are the multiple fragments which have been broken. Hardly each fragment would be around 2 to 3 millimeter or 4 millimeter. So usually such fragments of small size passes off. We usually place a double G stent at the end of the procedure so as to allow the fragments to pass down. So I'm trying to
Sir,
break.
what are the other methods of breaking this stone, sir?
So there are, the other popular method is a laser lithotripsy, in which we use a holmium laser. Holmium laser is an energy source which breaks the stone, and we also have a high voltage holmium laser to do a prostate surgery also.
Should we have to remove each and every small fragments, or we can leave it and put stents?
So that's what, small fragments of less than 4 millimeter, usually it passes off along the ureter. Okay. So for the stone fragments to pass down, we usually place a DJ stent. So this DJ stent keeps the tube patent.
Okay,
and
sir.
alongside the DJ stent, the stone fragments passes off.
Okay.
So depending upon the presence of fragment, we determine the time or duration when we remove the DJ stent.
Okay.
Sometimes a small stone in the lower aorta which doesn't need any breaking, or if it has been cleared completely, we usually don't place a DJ stent at all.
Okay, sir.
Whereas if it's a large stone, particularly upper ureter,
Yes.
where you have multiple fragments like this, so it's literally not possible always to remove each and every fragment.
Okay.
So
All upper ureter stones we can remove through ureteroscope, or we have to do some.
So there are three options for upper uretery calculus, sir.
Okay.
One is extracorporeal shockwave lithotripsy, which we can focus these shock waves,
Yes, sir.
electromagnetic shock waves from outside the body. So it can be done under sedation or even under local anesthesia if the patient is comfortable with the local anesthesia. But the problem is it can be done only for stones less than 10 millimeters. It's advisable.
Okay.
And even if it is done, the stone fragments have to come down. So
So you have to put stent for this patient.
yeah, we don't place a stent, sir. We usually, if it is less than 10 millimeter, we usually break the stone primarily.
Okay, sir.
So when you break the stone primarily, there is no need to place a stent.
Okay.
But we always tell the patient that there is a need for second procedure.
Okay.
So whenever we do an endourological procedure, there is a slight risk of redo procedure if ever the stone migrates, or if you see a simple pus pouring out from the kidney.
Yes, sir.
When you just break the stone, just pump. In such cases, instead of breaking the stone, it is better to place a stent and come out.
Okay.
So, in the presence of sepsis, urosepsis is very dangerous. So,
Okay.
in the presence of sepsis, we don't venture into breaking the stone. We usually place a stent, go secondarily after the sepsis is settled. Then again you have a chance of breaking the stone again.
Okay.
Okay.
Other than ESW, what else we have
So-
there for upper ureter?
So, URSL, which
URSL.
can be done with the RARS or a flexible ureteroscope in the standby.
Okay.
So, if it slips inside the pelvis like this and you are not able to retrieve, you are able to retrieve right now. So, if you are not able to retrieve the stone fragments, basket putching sister, not able to retrieve the stones,
Yes.
the kai vidinga sister, basket mattu putching, pump. So, not able to retrieve the stones. So, in such cases, a flexible ureteroscope which can coil inside the pelvis and it can grasp the stone, or it can be focused. Okay, I am removing the stone fragments with the help of basket. So, we can use a laser to break the stones. So, laser is a dusting mode where you can dust into small particles and you need not remove these fragments like this. There are certain hard stones where you have to remove the stone. So, these are the stone fragments. I had brought and put it in the urinary bladder. So, this will be hardly around 2 to 3 millimeter each. Okay. So, this is the ureteric orifice. Again, I am entering inside to see again whether any fragments still are there. So, still more small fragments, and just basketing it down and putting it into the urinary bladder. So, the other option in case of a large stone is you can push inside the kidney and you can do a percutaneous nephrolithotomy. So, if it is an upper ureter, a large stone.
Sir, what about the pyonephrosis? Where will you keep the stent in the presence of pyonephrosis?
Sir, actually, pyonephrosis ideally needs an external drainage. Pyonephrosis is a pus, whereas in case of a simple infection, a stenting would be sufficient. Pump. Whereas a thick purulent infection with severe sepsis, a better option would be to place a percutaneous nephrostomy. External drainage is always preferred in case of a septic patient, and then you can take him, you can do a stent under anesthesia, or you can go for a definitive procedure once the sepsis settles down. So, in the presence of severe pyonephrosis or something, pyonephrosis, it is better to drain the pus first, preferably via PCN, external drainage.
Okay. So one case we had 6 months back, sir.
Okay,
The
sir.
fever persisted for more than 2 weeks.
Okay, sir.
Finally, we found to have that patient pyonephrosis. Then we put, you only put that stent, sir.
Oh.
After that, the patient recovered pyonephrosis. But not external drainage. That was the stent was kept inside, sir.
If the patient is fit for anesthesia, we can go in for a stenting. If the patient is not fit for anesthesia, we can go in for a stenting under local anesthesia.
Okay.
Traction bridge. Usually, I put a guide wire and go enter inside, but with certain modifications, I now enter with the basket itself. Instead of changing, in urology, you keep on changing the guide wires, instruments. Traction bridge. So they have to start you in this way. Okay. So now we are entering again. This is the renal pelvis. Kidney may lift panna. So these are the calyxes. You can see the upper calyx. So here divides into two. So once you enter the calyx, you can see the renal papillae. Okay. So this is one such calyx here. You can see the renal papillae. Okay. So these are the place stone form. You can see a stone fragment at the 11 o'clock. So it's a phlebolith or a renal papillary calcification, which may form a renal stone again. So these are the root causes of the renal stone. Kidney lift panna. So this is the renal pelvis. You are seeing whether any fragments are there. Of course, a small fragment over here down. So lift. Okay. So these small fragments do come away. 10 cc syringe. Okay. So these are the renal calyxes. So here we have the lower calyx, which is exactly down. So which is not approachable with the semi-rigid ureteroscope. Okay. So these are only small kidney lift panna shakti. Small fragment over here, which usually comes down. There are no other fragments. So you can ignore this one. Okay. So these fragments, small size. So these two gets flushed out. Okay. Guide wire, stenting. So we have cleared the stone. We have broken the lid. So after this one, as I told, you usually keep a double J stent inside. So a double J stent purpose is, it's actually a tube which has a turn in the upper end and the lower end. So the purpose of the two J's are for the stability of the tube. Usually what happens, the kidney moves with respiration. Pump.
So the patient having less than 7 millimeter stones,
okay, sir.
But presenting with severe sepsis, diabetes mellitus, can we wait for spontaneous passage, or can we go for intervention, sir?
Nice
less than
question,
7 millimeter stones.
So less than 7 millimeter stone.
Diabetes sepsis.
So there are certain conditions where the stone must not be conservatively treated. One is bilateral ureteric calculus,
Okay.
Where the patient has a uremia or he has a risk of running obstructive uropathy and uremia. Another one is what you exactly said, ureteric calculus with sepsis. Okay, these two conditions need early intervention. So there is no role of conservative treatment in the presence of sepsis. Particularly a diabetic patient.
Okay. Okay.
So this is a double J stent which I already told. So this has J-like curve in the upper end and the J-like curve in the lower end. So it is for the stability of the tube. So because of the flow of urine and because of the movement of the kidney with the respiration, a simple tube will either pass down, or it may migrate upwards. So to prevent it, there is a J-like curve in the tubes on both the ends. So it's also called as a pigtail catheter or a double J stent. So now I had placed a semi-rigid guide wire inside the kidney, and over the guide wire I am going to push this tube, and I will be withdrawing the guide wire so as to retain the stent inside. Push. So as I already told, the other laser lithotripsy. So it's an advanced technology, but the problem is it is costly and it is not portable. So it is not always feasible for all patients, because all patients they are not able to afford for everything. So the laser lithotripsy is not portable also. So it's not possible to take to different hospitals. So the workhorse for most of the urologists is a pneumatic lithoclast, as I told. So this is the urethra, penile urethra, bulbar, so prostatic urethra, and I am entering the bladder. So this is the ureteric orifice. I had placed a guide wire, straight away. So over the guide wire, I am now passing a double J stent. You can see the double J stent. Double J stent has markings. A single black line means it is a 5 centimeters inside, whereas a double one is 10 centimeter. So it's a 15. So a bold line and a small line is means 20, and this is 25. So the length of the ureterus in adult is 20 to 25 centimeter. So well built adult, mostly it will be around 25 centimeter. So by now it would have reached the kidney. Just withdraw, sister. So I am advancing it. You can see the red pusher. Withdraw, remove. So I am removing the guide wire which is placed inside, and the double J stent gets coiled. Okay. So these are the stone fragments we can see inside. Small stone fragments. Grasper. So these stone fragments can be left inside the bladder, and the patient will be passing out. So this ends the surgery. I am just taking out one small fragment so as to show you how large or how small is it. So this is a tri-prong grasper with which I am holding the stone fragment which is placed inside the bladder. Usually the patients get satisfied only if we show the stone, because there are multiple quacks who do take the stone from outside. So when we do a proper surgery, if we don't show the stone, our legibility is lost. So this is a stone fragment. It will be hardly 2 to 3 millimeters. Okay, this is the largest fragment which is seen inside. So other fragments do come out. Okay, thank you. Catheter, 14.
Thank you, sir.